welcome to Planetary Health First, Mars Next. It is super amazing. Great day. We have Dr. Wayne Pan, and we get to call him Wayne because we're a friend of his. So we have on Bring a Friend series, we have a friend, Wayne, and he is no stranger to healthcare. I mean, he's done a lot of things. And I'd love for you to just share real quick, Wayne, just a little bit of your background before we dive deep into this.
Sure. Yeah. So I started out as an orthopedic hand surgeon and practiced for about 5 years in various settings, including Kaiser and academic health centers. Then decided to direct my career to fixing healthcare and spent about 5 years in managed care and public health plans, such as San Francisco Health Plan. Also did 5 years in managing physician groups in Northern California, largest physician group in Santa Clara County. And then worked in healthcare technology, also for about 5 years, worked in biotech, also for about 5 years, and then did my own startup in chronic care management, remote patient monitoring, and that was also about 5 years. So, happy to be here.
Well, it's great to have you here. Charles, do you want to start it off? Do you want to ask a question?
Yeah, I'd love to ask a couple of questions. So my name is Charles Gellman. I'm the CEO of HIDO Health. We specialize in AI robotics to take care of the underserved and at-risk patients that are on multiple medications. So I would love to kick it off because a lot of folks think public health plans are very slow to move from an innovation standpoint. Where do you see that where public health plans have advantages or disadvantages when it comes to adopting new technologies or new innovations and servicing, your particular members?
Yeah, I think, I agree with you. I think public health plans are probably the least likely place. But on the other hand, they have the most need, right? So this is a situation where there's not a lot of resources. We can't up the premiums for these members. And typically we pay them the least. We pay the providers the least. So we have to be innovative in order to sort of stay ahead of the game. And we also have the hardest patients. So it's a great opportunity, actually, for the public plans to embrace technology and innovation as a way to be more efficient and more effective with the dollars that we get.
Yeah, I think that's quite unique and quite interesting because when you start thinking of those dynamics, typically they are, high cost, high risk patients, lower income or socioeconomically disadvantaged, and being able to have the ability to touch them and manage those patients are, quite a large dynamic. So as you see the next 2 to 3 years unfold, is there any particular things that you think that you're doing differently or the public health plans are doing that are very unique as a whole to serve these particular members?
Yeah, I think in California, we're kind of ahead of the game in terms of the Cal AIM program, which is trying to invest in other assets in the community to help manage these patients. And that includes housing, social support, food, things that you typically don't think a health plan would be doing. We're actually looking at those as ways of helping our members get the best healthcare.
So what do you think is the biggest challenge that you're seeing as you lead health plans to the future?
I think the biggest challenge is, what's the role of the health plan vis-a-vis the providers, vis-a-vis the vendors, pharma, biotech. Where does the health plan play, and how can the health plan be a facilitator to bringing in things that will make the patient much healthier and easier to manage?
Mm-hmm. And your background's very unique. You've spent some time, creating your own business. You spent your time working at other different health systems in different capacities, and now you have a different role here, managing or basically servicing a large population and trying to determine what type of levers you pull. In regards to where you spend those limited dollars, are there particular areas of focus that you think are a huge value add versus maybe some of the hype that many people are speaking about in the marketplace?
So I think every health plan is different because the members are different, the providers are different, the environment that the members live in is different. So what I see at San Francisco Health Plan, and I'm not speaking on behalf of the plan, but I'm just seeing what we see is that, certainly the homeless condition is something that's very challenging. So if you don't have a stable home environment or house, then that's something that we need to be able to try to fix. I think other pieces of it is access, right? Getting access to specialists and also primary care doctors, because it's, if you try to contact somebody in the healthcare system recently, it's a zoo. It's a mess, and we as a health plan need to do better to help members get access to the providers who ultimately do the work that we're asking everybody to do.
So
Yeah,
how do you figure out what's the right vendor? I mean, I imagine in access play you must utilize a lot of vendors. How do you go about that?
Well, so for access, it's our provider network, right? And so what we need to do is we need to balance the breadth of the provider network and also the ability to manage those providers, if they're doing things incorrectly. For the most part, every provider is doing the right thing, but there's certain times where we have to, educate them on what are the evidence-based practices so that those are adhered to, and that's how we reimburse them and how the members should be treated.
Mm-hmm. I think something interesting was you mentioned healthcare access, and Governor Newsom in California recently expanded Medi-Cal to a number of undocumented people across the border. How do you foresee that potentially impacting providers? Because now the bandwidth has been increased by 700,000, some odd folks. Do you think your members could have additional access problems because there's now so many more people to serve in the area?
So this is something that, it's a politician's sort of game, right? These members or these people are actually still seeing healthcare, right? They may not be seeing them on a regular basis, which should make it cheaper and easier to manage those conditions. But they show up in the ED, and the hospitals actually bear the brunt of this because those are cash-paying patients, and there's no follow-up essentially, and so they only come in when the things get at the worst, right? They have really bad high blood pressure, they have bad diabetes that's not controlled, and they're reluctant to go in. So it's only when they absolutely have to, and the hospital has to pay for it because these people aren't going to be able to pay for their bills in cash. So it makes sense. It's a way of providing the care in a more reasonable and rational way, so that we can manage this population. This population still lives here. And I'm a firm believer that healthcare is a right, not a privilege, and we can afford it. We spend over $5,000 or $6,000 a year on healthcare per person on average, and the nearest advanced country is a third of that. So we have tons of money that we're spending that we can certainly spend better, and that's what our job is.
So with the I guess, how do you see that what could you do better? What if you could wave the wand or make it the way Wayne's plan? What would that be?
Well, I would eliminate those things that are barriers to care, right? So one of the things that we have baked into our thinking about health plans is that when you get a prescription for a medication, there's a copay. And it doesn't make any sense to have a copay because honestly, if you're living paycheck to paycheck, you're oftentimes deciding between paying for drugs or paying for food. And that shouldn't be the case, right? If you have healthcare and a prescriber, a doctor has said that you need this medication and you should be getting it, you shouldn't have to pay additional dollars and make that a barrier. That's just one example. Same thing with access to preventive care. That should also not have copays or coinsurance or any other barriers around it. If you're supposed to get a mammogram, you should get it, regardless of, it shouldn't cost you additional money to get that. There are lots of things that we sort of think that that's part of what we should be doing, but we need to step back and say, does that really make sense? Does it make sense to create a barrier for the treatment for somebody that needs it and it's been documented? It's not like we in the US can go to any drugstore and pull every drug off the shelf and take it home with us, right? It's gated through a physician or a nurse practitioner or PA, And that should be something that should be all it takes to get that. And that will help, right? It's not going to be the whole answer, but that will help.
So let's just imagine if those barriers to care are removed and those copays are removed. The way I see the pillars to prospective health for a lot of folks, are dependent on nutrition, diet, you have mobility and exercise. And then the last one you mentioned were medications. So if you're able to unlock the medications and provide those for the patients, and their the copays disappear through a health plan or a zero cost, then what do you think would happen with those at-risk patients in the home? Do you think it would drastically evolve into a situation where there'd be a reduction on hospitalizations or ER visits, or how do you see it unfolding?
Well, like everything in healthcare, it's going to take time, right? So the immediate effect is that hopefully patients will be more adherent to their treatment regimens. That's number one. The other things that you mentioned are all behavioral, and I think health plans need to invest in things that can help members change their behavior, even if it's just one little tiny thing, like taking a couple of steps towards a walking program. It doesn't have to be anything to run a marathon, but they can get more active, eating more fruits and vegetables, partnering with local groceries to make it cheaper to buy fruits and vegetables, creating places where they can get fruits and vegetables in those food deserts, right? Those kinds of things. Those are all the things that CalAIM is trying to do. And so I think, we're starting, baby steps into that direction. But at the end of the day, lifestyle is probably 80% of the cost of managing chronic conditions. Whether it's smoking, losing weight, being more active, eating a proper diet, getting better sleep, less stress, all those things that typically the doctor spends 5 seconds on at a visit is actually the thing that's going to change the way that we manage these chronic conditions in the population.
Yeah, so with exercise, sitting, I guess chairs are the new cancer, right? Or the new cigarettes, right? We're all sitting, right?
Yeah, sitting is, obviously what we do every day if we have a desk job, but that doesn't preclude us getting out to just do a 30-minute walk, right? It's really not like you have to run a marathon or be an Olympic, sports, person. It's very simple things. And it's cumulative, right? So it's a matter of just starting somewhere and just continuing to do that. I think that's something that we don't learn in medical school because we're not focused on that. We're focused on the diseases. But in reality, the highest ROI is if we can get a member or patient that formerly was just sitting on the couch, watching TV all day, to actually taking a 30-minute walk, ideally after a meal. That reduces the blood glucose spikes and also improves their cardiac condition even just a tiny bit.
And dancing too, right? I've heard that dancing is the best thing you can do for mental health.
Yeah, absolutely. Well, I mean, one, it's social, right? So we're social beings. And one of the things that we learned in COVID is that isolation is actually very detrimental, right? We have to have that social connection. And particularly in the elderly population where, a lot of times they don't get out because either they're afraid to, or they, their physical condition doesn't allow them to be as mobile. Social is definitely the way to do it. And dancing, obviously is great.
So I know, sorry, go ahead, Charles.
Yeah, I was going to say, let's continue down that same thought or logic around dancing and singing. And some of those older populations are actually in the home, or maybe they're in a group setting. What do you think, from what you've seen in the past, is the best way to engage these folks, knowing that they're isolated or they have, mobility issues and they can't get out? Is there, specific technologies or things that you looked at from a mobile standpoint or other type of electronic devices to actually engage these members so then they feel that someone's looking after them?
Yeah, so there are lots of sort of apps that connect people, right? So one is to connect their seniors with their loved ones, but there's also local groups, right? So I sit on the board of San Francisco Village, which is a local nonprofit volunteer organization that's designed specifically to help seniors age in place, because that's where seniors want to live. They don't want to live in an institution. They want to live at home. And so if you're isolated, the village will provide volunteers that can come take you out. They have groups that you can meet up with. So there's nothing that replaces sort of the human to human connection. Now, technology certainly can help. So they also have online sessions where you can get together on a Zoom call and discuss various things that may be of common interest. So technology is helpful. I think it's good to use as a monitoring device to make sure that your loved one is actually doing something, getting out the door, having activities, that kind of stuff. But the human connection is actually the best thing to do.
So when you each year, I guess, how often do you redesign? What is the process of like designing the plan in order to make it work? What does that look like? Gosh, that must be a committee of committee meetings.
Yeah, so the sausage making isn't that pretty, but at the end of the day, we are focused on, the main thing we're focused on is that members get high quality, good access to care. And so it's not too often that we have to redesign something, but we certainly might add different programs. And we often turn to the providers themselves because they're at the front lines actually seeing the patients, and they'll send in a grant application to say, hey, let's try this type of group, or a group meeting, or a learning session, or education program, or a technology. And sometimes I could bring the technology too to say, hey, could we try this in a way that will be a demonstration, and if it works, if we calculate the ROI and it's positive and it seems like people enjoy it, then let's try that.
What like is the level of scope that it has to be to see some sort of statistical significance? Like how you know if it's like to roll it out and how it's working? Like what do you do?
So there's no secret sauce, but you kind of want to understand what are the parameters that you're trying to measure, and is it easy to measure, and then essentially set a target, right? And then you do statistics to then figure out what your sample size needs to be and all that kind of stuff. But we're typically not that scientific about it. We're trying to basically use a broad stroke to say, hey, we have an issue with X, and these things can be done to maybe improve X over what we currently do. Let's just give it a try. We'll try it with this population. And then we get feedback. And if the feedback is good and everybody says, hey, this is great, then in general, we would then adopt it as long as there's no other barriers to doing that.
And providers often are constrained with resources as well as the time they have in the day. So to your point a little bit earlier in the conversation, they may have minutes with these patients. Are there better ways to reach these patients in the home where providers are not expanding their time during the day because they only have so many hours? Do you have any population health coordinators or case managers or something that's unique and different so you can impact a lot of those patients in the home versus when they hit the hospital or the ER or the actual doctor's visit 6 months from now?
Yeah, no, that's a great point. So we have a care management division that actually reaches out to the high-risk patients and then connects with them on a one-on-one basis to try to get them the care that they need or coordinate things for them. We also have some home visitors that can go in and visit the patients, typically nurse practitioners, and they could do an assessment. But those are typically for patients that are homebound or have some reason why they can't get out. We really encourage them to meet PCP in the office. We haven't really delved into we have telehealth access, so our members can access teledoc, but it's limited what they can do, right? Medicine is great, but it's not the solution for everything.
Mm-hmm. Yeah, I think there's a magical paradigm. If you were to create a health plan where you have everybody aligned from an incentive standpoint, you have the patient aligned with the provider, with the health plan, with the pharmacy, you have all of the groups come together as one. So then holistically, if you look at the patient at home and you can increase their wellness and some of those things that we talked about, having the right food and nutrition, having the right behaviors when it comes to exercise. And if they need to take medications, taking the minimal amount of medications to sustain whatever that chronic disease state, so they can dance and they can sing and they can do a lot of those behaviors that make them happy and healthy for a long period of time.
Right. Absolutely. Yeah. It's the holistic approach to the person, right? It's a whole person care is what we call it. And definitely we need to look at outside of the four walls of the clinic and then outside of the patient's home, right? Those are the two things that were typically constrained in traditional medicine and traditional healthcare.
Wayne, I want to make sure we're respecting your time. I got about 5 more minutes, so this is the moment to drop whatever you want. The secret sauce behind the machine, or any other topics that we might miss or have missed.
So I think one of the things that we often talk about, but it's not easily understood, is the data behind healthcare. And I think for the future, data-driven decision-making is really going to be key, right? Being able to understand the patient at a more granular level, particularly outside of the home, the data about providers and how they do things, whether or not they're evidence-based, and then the performance of the plan and each of the initiatives that the plan has. What is the data behind that? So that at the end of the day, the plan should really act like a venture capital firm. And we're investing in our population to help make that population healthier. So what are the things that we're doing to encourage that, whether it's creating new programs, getting new providers, new technology, having members access to different things so that they can do the right things. Those are the things, that's what we should be doing. And with driven all by data. And if we get the data, which we have abundance of, we should be able to make more sense of this and then be more effective at investing and creating things that are much more positive for the patient.
What kind of timeline do you need? Because like the investing, like I know you guys have plenty on all the premiums and all the laying out all that actuary stuff, but in order to do those investments with ROI or new programs, like what is that time horizon where you have to see it?
So it depends on what exactly we're trying to move, right? So the bigger needles will take longer time. The smaller things will take shorter periods of time. So for example, let's say we want to reduce readmissions for a particular condition. We have to look at what are the things contributing to sort of spending extra, right? So whether it's medication adherence, whether it's access to specialists, all those things will depend on whatever the condition is. And then we would set up a program talking to all of the stakeholders, or as much as we can, the providers, the specialists, even patients, asking them, is this going to help you? And then essentially setting up a program saying, okay, this is how we're going to do it. We have to probably do a couple iterations because the first time it's not going to work. And then once it's sort of running, at least a 3 to 6 month time frame to be able to measure some type of effect. Now, the readmissions is actually pretty easy because if you take a high-risk population that gets readmitted pretty quickly, then we should be able to see an effect very quickly. But if it's longer, let's say obesity, right, which is obviously a big thing, no pun intended, it may take a year or two, right, to be able to see any kind of effect on weight or BMI or whatever the measurement that we're using. So we have to be flexible, but we have to be data-driven, and we have to be in good communication with our partners.
Well, this has been great having you and Charles on today. Charles, Wayne, is there any last-minute takeaways that you'd like to throw out there in the universe to hit Mars and maybe come back again?
Yeah, get active. Everybody should be doing something active every day. It doesn't have to be 30 minutes like people say. It could be 5 minutes. It's just adding every day, more and more.
Yeah, and I'd like to repeat, just staying active, eating healthy, and then if you do have to take medications, take the least amount possible so then you can maintain a good, healthy lifestyle. Engage with your community. There's a lot of data behind being happy and healthy for a long period of time. So dance and sing and enjoy yourself.
Yeah, and get on podcasts and talk and meet friends and have a good time too, right?
Absolutely.
All right. Well, this has been great. We really appreciate this conversation with Charles Gellman and Dr. Wayne Pan on Planetary Health First, Mars Next. And I really hope you've enjoyed this journey today with us. Thank you so much, friends. Till next time.